Monday. Welcome back to the Compliance Guy podcast. We have a quorum today. So we have Paul, Terry, and Scott. Stephanie and Christine will be back for the next episode. And we'll leave it at that. So with that said, Terry sends me a message this morning with a video, and she's like, "Oh, this is just my view here at the Four Seasons. The only Four Seasons I get are the ones here in Georgia, okay? Like when I go on a trip somewhere, I'm staying at like La Cucaracha Inn if I'm lucky, especially after what my wife did to me in Vegas. But that's another story for another day. So we're not even going to go there. And I know Terry's probably going to start texting Jill and being like, oh, Sean's talking about your gambling issues in Vegas. But we're not going to do that right now. So it's been 5 weeks since we've had an opportunity to all get together. Terry and I have done our hashtag Terry Tuesdays. We've stayed on top of that. Terry and I have a brand new episode coming out tomorrow. So stay tuned for that. But it's good to be back with Paul and Scott. I got a chance to hang out with Scott a couple of days this past week. We were both at the American Alliance of Orthopedic Executives, AAOE, in Atlanta, Georgia. I gave a talk on Friday for artificial intelligence and healthcare. We're going to talk about that some later today. And then Scott gave a presentation on what on Saturday?
Provider education, tactics to educate your providers on audit results in a way that's hopefully a little more sticky.
Good. And I mean, listen, that's an area that we get a lot of questions. I know, Terry, you get a lot of questions. How do I present these findings and maintain our providers' interest? How do we get our point across without being inflammatory, using the F word that nobody wants to hear, stuff like that. So big topic. We could address that later. But in the meantime, Paul's been staying extremely busy with some wild audits, things that are just really, really going unbelievably sideways for some providers. And it's not unexpected. And I'll talk about the reason why it's not unexpected and what some of y'all should be preparing for the rest of this year based on some very telling comments that were made at the HCCA conference that I was at this past week in Vegas, especially coming from the deputy chief, Kimberly Brandt, who's absolutely a fascinating woman. Every time I've had the privilege to hear her talk or to read things that she's put out there with respect to what's going on at CMS, always insightful, great information. But some of what she shared at HCCA, I want to talk about that just a little bit later, but I want to give Terry the floor because, as always, Terry gets these interesting emails and these things that go on. And she said, "Hey, I got an interesting topic. It's outside of the ones that you put out this morning, for the podcast. So let's talk about it." So, Terry, floor is yours.
Okay, and apologize to everyone. Yes, I'm in Hawaii, so if you hear birds and surf, sorry, and a dune buggy apparently, but I will mute when I'm not speaking. So, and it was only 5:45 when I got on the call this morning. So I got an email that said, I listened to your podcast, I listened to the Compliance Guy with all the team on there, and I have a question, and maybe you can ask Sean to bring this up. And I thought this would be a perfect time. I just got this morning. It says we have a new biller coder, and our super bills have been changing. She adds the G codes to our notes, sometimes changes level. I only do this to get Paul's reaction and Scott's reaction. She says, she adds the G codes to our notes and sometimes changes level 3s to 4s and 5s. My boss keeps telling us that she's a certified coder and she can do what she wants. However, clinicians are not informed of these changes. How did we find out? Patients are bringing in their EOBs and saying, why am I getting charged for depression screening, complexity code, alcohol screening, when I don't have any of these things? Could you shed some light on this topic? We're concerned about we don't know the right way to handle it. And here's what she said. We wish sometimes that Medicare would just audit us. So,
Oh, wow.
oops.
There's ways to make that happen.
I
Yeah.
know that if you wanted to make it happen, you're doing it.
Yeah.
So obviously, you can't upcode. I mean, you can, if you're a certified coder auditor, if it's in your policy within your practice to down code, that's that's something that you have to decide if that's something you want to do. But you can't upcode a physician without their permission and without them knowing, because ultimately they're responsible. And just taking, and actually I'm going to throw this one to Paul, just taking a diagnosis, maybe they saw something that the patient was anxious or the patient was something, and then throwing a screening depression code on there. Can you imagine?
Yeah.
What
Well,
would
the
you do
the
if you saw that?
the first the first thing that jumps into my mind is perhaps this coder worked for a Medicare Advantage
I
program.
know. There you
You
go.
know,
Yeah.
but this is what a query process is for: an effective provider query process. And no physician suggests ever think in their minds, "Oh, I have a coder that handles that." You know, in the end, I mean, geez, we're now in year 27 of me being a certified coder. I really need to have a stroke or something and just let this end. But, when, if, if I'm coming to you as a coder, even with all of my expertise and just the time and investment that I've put forward to being a certified coder, I'm still not a clinical person. I still don't have a clinical history of that patient. It is the physician or the nurse practitioner or the physician assistant in their role as the person who's providing direct treatment to that patient that can really paint the clearest clinical picture. It's not up to us to just say, I think that's moderate complexity. And so I'm going to bump it up. I mean, that's what the query process is for.
Yeah,
You,
because the G
you know,
codes is really concerning.
yeah, that is somewhat concerning, particularly, the one area that I'm thinking about is what if a person is coming in for a preventive examination, and all of that is part of a preventive examination. It's not like you break out pieces of a preventive examination saying, I see this and this and this and this and this. And let's, there's an old term in nuclear weapons called MIRV, multiple impact reentry vehicles, where there's one missile, but it breaks open and there are 25 missiles inside it. That's not medical coding. That's military missiles. Try not to do that. And when in doubt, NCCI edits, even though some of them will allow all of these things to be built together, just because you can doesn't mean you should.
Well, and Scott, I'm going to throw this to you because this is something that Stephanie and I talk about, Christine and I've talked about, Sean, you and I have talked about. I think we've all maybe commented on it. A lot of times when the doctors see the money coming in, they don't, under or realize that that's not the the end all. Just because you see the money and all of a sudden they're like, well, we don't want to make that person stop. We're happy that they found these charges to bill. And it just really concerns me because what I do in my audits, for example, if I do see a patient that qualified for the G2211 complexity code, or I do see that, hey, are you charging this? That, like Paul said, I go and send this to the provider, send it to the administration, say, hey, I'm noticing things that you could potentially charge for on XYZ patients. Just be aware of that instead of just automatically putting it on there. Scott, your thoughts on that?
Yeah, so the first thing I want to say, that the doctor that had said, she's a certified coder, she can do what she wants. As a certified coder, I'm going to start saying that in all aspects of my day-to-day life. Like if I'm trying to cut like a giant line or something, it's like I'm a certified coder. I just do what I want. On a serious note, I think alignment is important, and I think you raised a very good point that when someone is hired and brings in a lot of extra revenue, the easiest thing to think is the most optimistic or best thing from your own perspective, which is, well, we finally got some expertise in here, and this person is, getting into the weeds and finding all these things we could have been billing and bringing in all this extra money. But I think, we all benefit in life from being scrutinized or having our work reviewed. And I think any individual who's making decisions in an organization that have potential, compliance implications, potential, accusation of fraud implications, potential CMS audit implications, we want to scrutinize that work, right? Somebody wants to come behind and say, I've reviewed this, or, Terry, to your point, there's a difference between, if I were to be hired somewhere and I were to look at the billing and say, well, I think this provider should be billing G2211 more. There's a difference between engaging the provider, engaging administration with that versus saying, well, I'm going to start adding it to code. So I would say from my perspective, speaking specifically about G2211, I've told every client I work for that philosophically, I don't add it to their audit results. I don't go in and say, well, I'm just going to make a executive decision. I don't even work for you, but I'm going to make an executive decision to add G2211. I think it's a conversation point for my education just to say, well, you have these situations where it appears from my perspective that it fits the format or meets the requirements of G2211. But do you want to have a discussion organizationally about whether or not you feel it's appropriate, what circumstances you believe it's appropriate? And I think the benefit of that is you give the client, you give whoever you're engaged with, even if it's within your own organization, sort of a global piece of education about it and enable them to understand, okay, this is sort of a philosophical decision I'm making about when I think it's appropriate or when it's not. And, to give you an example related to G2211, I've had at least one or two clients that I work with who I will talk to the providers about G2211, and it's typically they're not applying it correctly, and they're saying, well, this is a prompt from the EMR, and I just add it every time I get the prompt. But I don't really know whether or not I'm adding it properly. And so I think, I went in a few different directions there, but I think, when it comes to these types of decisions and their implications, you're far better off having a conversation about what the best approach to move forward is. To Sean's point, I spoke at the AEOE Saturday, excuse me. And one of the things that I said, which I say in a lot of presentations or when I'm asked sometimes about how I would describe my audit work in 2 sentences, I say my job is to reduce risk, not increase it. And so, I'm always thoughtful about that when I'm making decisions regarding charts. It's like, am I seeing something that's causing me to place a risk on this person that they might not otherwise place upon themselves, versus having a conversation about why we might code things a little bit differently.
Yeah, and that's funny that I'm going to make that a bumper sticker. I like that. But
So
but
let
Sean,
me,
the one thing that concerned me here too is she said that they're upcoding. They're putting instead of 3s to 4s, and you deal with that. But
yeah. So let me,
no,
I take a little bit of a different approach to it, right? Because for me, I look at this as an unauthorized alteration of the codes on a super bill, right? And when that happens, it carries significant legal risks for both the individual coder, but also the provider, right? So if you think about it, and Scott kind of alluded to one of these already, which is, the False Claims Act. So Terry, to your point, specifically on upcoding, if a coder changes a physician's documented code, especially to a higher level or more complex code, the resulting claims that get submitted to Medicare, Medicaid, or private insurers could be considered false or fraudulent under the False Claims Act, which means it could lead to civil penalties and treble damages. I mean, claims could reach up to $23,300 per claim. But here's what's more important about this under the FCA for a potential coder. Under the False Claims Act, the FCA requires proof that the submitter knowingly presented false information. But if you look at it in this light, a coder who alters codes without the physician's authorization can be deemed to have acted with reckless disregard for the truth. So it has nothing to do with knowing. Remember, under this, it's either knowing, deliberate ignorance, or reckless disregard. Now,
but sometimes the doctors always want to say, "Well, my coder did it. I didn't do
sure.
And
But
it's like you can't know you're responsible for what goes out with your name on it.
that's right. And so we could transition from the DOJ over to the OIG, because when we talk about CMPs, right, civil monetary penalties, we could also talk about the fact that this includes program exclusion. So keep in mind that the Office of Inspector General can impose monetary penalties for misrepresentation on claims, or for those of you that are in a hospital, if you're filing cost reports. And what they actually talk about is habitual or egregious coding alterations could trigger exclusion from the federal healthcare programs. So if a coder is found complicit in fraudulent billing, they could be booted from participating in the federal payer programs for any role, whether it's a direct role in remunerations or an indirect role. And this is for Medicare, Medicaid, and other federal payers. And an exclusion lasts for at least 5 years. But beyond that, the physicians have to worry about licensure risk. If you work for a hospital or a large physician group, being sanctioned by that group, there's also criminal exposure. I mean, if this is a scheme to commit a conspiracy, or, a scheme or an artifice, now you have criminal exposure. So I think it becomes very important that, internal audits are performed. Scott, you alluded to this. You got to have some kind of dual control process in place, right? Physicians can't just bury their head in the sand and say, well, I didn't know. She's the coder. She's certified. She can do whatever she wants. That's stupid.
Well,
right?
you also, I think the biggest thing, and I think Paul hit on this, it's unauthorized to just do this and not
Yeah.
get physician permission to upcode, because this is all upcoding. And that's a buzzword that I've been in a lot of different arbitrations
Yeah.
and just, defense work stuff, or they love that word.
Well,
I'm saying prosecutors love that word. And
Absolutely.
so you have to be so cautious about unauthorized upcoding. And how did they find out? The patients, they didn't even know. Them
Yeah.
bringing in their EOBs. Yeah.
well,
So I know you have
and
other topics, but this is
I
crazy.
think that last point I just wanted to add to that, because it speaks to like that lack of organizational control, that lack of understanding of what's going on within your own organization, that you could potentially hire one person, and now however big or small this practice is, I mean, it's there might be an administrator, practice manager, there's obviously the clinicians, and to have one person be able to go out and make those decisions in an unscrutinized way. Sean just talked extensively about the appearance of fraud and things like that, but what does it say about your organization that all of these things started to happen, and the only way you found out about it was the patients started to bring in their bills and ask questions? And I think it brings me back in some respects to what I'd said before, what we had talked about earlier. The money is a blinder to what the right thing to do is in some instances. And I would just add to that, to be thoughtful about as you're bringing people into the organization. Look, I will say this in the nicest way possible. I think it applies to a lot of professional certifications and licensures that exist, but the process of acquiring the license, the way in which you are tested for the license, is often different from how you use the license, like in the real world, right? So when I take an AAPC coding test, there can only be so much nuance in the note when the answer has to be A, B, C, or D. Like at some point, the note has to like produce a correct answer. And unfortunately for us, when you start to read actual notes created by actual clinicians, you don't always have that level of clarity. So I think, I say that only in the construct of when we say that somebody is certified, it doesn't mean that that person shouldn't be onboarded, that that person shouldn't be brought in a way that their decision making aligns with the organization. So, the organization that I work for, and Paul works for, and Sean works for, we hire people to do certain jobs all the time, and they have certain skills. But when it comes to like the auditing of a provider note, I don't just say like, welcome to the company, it's your second day. I'll just assume everything you do is exactly in line with what we would do, right? Like we review it.
Right. That's
like,
why we
for that
have an
reason.
extensive quality assurance program. I mean, every person who starts with our company until they get signed off by one of the seniors goes through an extensive auditing process, right? And QA process, because again, we don't ever want to be brought to an argument between the government and a group where they say we were complicit in our responsibilities as an independent, objective third party reviewing documentation. Same thing for Terry. I mean, there's a lot of liability in the work that we do as regulatory compliance professionals, as experts, as independent third-party auditors, coders, whatever you want to associate, as terms for the kind of work that we do. So we have to stay on top of that stuff, and there's no guessing. We can't guess when somebody sends us a document. And I'll give a great example. We had a client last week that sent something to myself. I reviewed it. Again, I am not I have all these certifications, but I don't spend as much time in the CPT books and in the nuanced work like Paul, Terry, Scott, Stephanie, Christine, right? I'm looking at, how do we build a defense on a case, to help this law firm or to help this client who's been targeted, or, how do we write a report in a certain way so that it helps an administrative law judge understand why, what we're going to present, why we're going to present it, and how the government's assertions are garbage to a certain degree. But, I sent back my response, and then they sent back a response from the facility coder saying, well, this is my take on it, and da-da-da-da-da. And I got to the point where I finally said, hey, you know what? I've taken it as far as I can based on my knowledge of this type of service. Let me give it to Scott, because he's really the technical person when it comes to this kind of thing. And I think, in wrapping up this conversation, so we can move on to our other topics, I think that's what needs to happen within organizations. I think you've got to have a process by which, there's oversight of what's going out the door, because a provider saying, I didn't know, is not a justified defense. I mean, sure, you can make that argument, but at the end of the day, your signature on a CMS 1500 form is an attestation that everything on the front of that CMS 1500 form that's being sent to an insurance company is accurate. So be cautious and be aware of what you're selecting as codes versus what is actually going out of your office. All right, let's move on to the next topic. And this can be a very quick discussion. So I was at the HCCA conference in Las Vegas this past week. Got an opportunity to meet a lot of folks that I've never met before. Got an opportunity to say hello to some old friends. Got an opportunity to sit into some education set. Well, not some. I needed 20 plus hours of my education for my CHC to be able to maintain it. But one of the sessions, excuse me, that I sat in was Kimberly Brandt from the Centers for Medicare and Medicaid Services, who was tasked by the new administrator, Dr. Mohammed Oz, to come back and to be basically his deputy chief, if you will. And one of the things that Kimberly talked about is that the fact that the Trump administration, which is sort of about deregulating. So if you follow anything that President Trump says, for every one new law or regulation or statute that is created, 10 have to be taken away, right? That's his concept. That's his thought for how to do it. But it was very interesting to hear Kim talk about the fact that audits are not slowing down. If anything, she fully anticipates under Mohammed Oz that audits are going to escalate beyond where they're at right now. And it doesn't matter whether you love Dr. Oz, you hate Dr. Oz, you don't know who he is. The bottom line is This guy has made a pledge to ferret out fraud, waste, and abuse. He is targeting, with the help of his advisors and other people, very specific areas. And I want to jump into one right now, if we can. And again, we could keep these conversations pretty short. But Scott, I want to start with you. And then Paul and Terry, I want to come to you guys for the other things, because I know you both have extensive knowledge in these areas. So, Scott, skin substitutes. This is an area, and Paul, I know you have exposure to this as well, so jump in. And Terry, I'm sure you do as well. So jump in if you don't know. Terry's like, heck no, I'm not touching it. Okay. So skin substitutes, orthopedic practices, those dealing with wound care. Y'all better pay very close attention to what's going on. And Scott, talk about what the requirements are, and Paul, from a documentational standpoint and from a coding standpoint with these skin substitutes.
Yeah, so I just want to say at a high level, just so the people who don't do skin substitutes don't tune out. Anytime you are offering a new service, whether it is a supply code service, whether it's some new technological advance, whatever it is, that's going to become a potentially significant amount of your business within your practice. It is imperative that you understand completely and fully all of the requirements that sit behind this service, essentially from the ordering process through the documentation process, through establishing the medical need, and through the follow-up. So one of the things that we've all been dealing with quite a bit, except for Terry, is this notion of collagen wound dressings and when and how they are used. And so, I believe that the original intent of these dressings were to address or aid in the healing of wounds that are otherwise recalcitrant to healing for various reasons, right? They could be related to diabetes. They could be, we're all different people and we all heal at different rates. And so these collagen dressings are intended to essentially, I believe, reduce the scarring, increase the healing rate. And, the government has policies related to their usage. And now I have said, and I will continue to say this, is that I don't think these policies are particularly well written, because I don't believe that the intent of them was that every single surgical wound that was created would somehow require some sort of collagen dressing. Another of the sayings that you'll hear me say many times if you listen to me often enough is that Medicare is not in the business of paying for the steak. Medicare is in the business of paying for the hamburger. And for a lot of these wounds, the collagen dressing is the steak, right? Like the wound is going to heal. You may, if I'm an 85-year-old and I'm having like arthroscopic knee surgery, a case could be made that I don't need like the best of the best of healing. I need a healed wound with a scar. Anyway, these collagen services require an order, require an explanation of how and why the wound is being used. The wound has to be measured, height times depth times width. There has to be a description of the amount of exudate from the wound. And I don't have the policy open. I think there are a couple of things I'm not even mentioning. Now, the kicker, the part in the infomercial where they say, but wait, there's more. When the patient follows up for these collagen dressings, the policy basically says the patient should be followed up with at least monthly, but potentially weekly, depending upon the need. Once again, you have to document the size of the wound, length times width times depth, quality of the healing, number of wounds, location of wounds. And the next time I see all of that documented appropriately in one of these follow-up notes will be the first time. And so, for the RACs and these various auditors, right, this is like grabbing your fishing pole and going to a pond where they just dumped like 500,000 fish. And so all they're doing is they're requesting these records again and again and again, and they're clawing back this money. And these collagen dressings are not cheap.
Yeah.
And that's before you get into the fact that, a number of the vendors that are in the business of assisting with these dressings, and when I say assist, they basically, here's some of the things that I've dealt with. Patients who were not informed that they were going to have a cost potentially up to the 4 figures behind these dressings. One one client said that it was the vendor who entered the measurements for the wound. Now, if you're in compliance, I'm going to say this again and let this sink in. The actual provider who performed the service did not measure the wound that was generated by the surgery. The vendor entered a baseline measurement of what a typical wound would be like, height, width, depth, based on the nature of the surgery, right? So if the incision is in the knee for arthroscopy, that's going to be one type of wound. If it's in the hip, that's going to be another type of wound. And so the sizes were all of these standard measurements that were not the actual size as measured by the provider. So, I've put a lot out there.
Yeah.
And I think that it sort of goes back to what we were talking about before, right? Like there is such a thing as fool's gold for those of you who were in the gold rush in the 1850s or have read about it. And, these orthopedic practices, this is it's generating a lot of revenue. So when you're sitting in the meeting where they're explaining it to you and what the payments are going to be like and what the documentation requirements are going to be like, if I were in that meeting, I would think, well, this is a way to significantly increase our revenues. It's not a lot of an extra lift for us. And, look, the policy, as is poorly written, seems to suggest that we can use these. But I don't believe it was the intent of these policies for like a literal 1-inch wound generated as part of like an arthroscopic procedure. And most of these notes I'm reading, the patients are in a month later and it's like, well, the wound is well healed, the wound is closed. So why are we doing it in the first place, right? And so there is an extraordinary amount of compliance activity around these wounds in particular. But like I say, I would expand that to just say anything that you are doing, you want to know every derivative of that policy, because I've worked with another group on facet joint injections where it's kind of the same thing, right? It's like there are a bunch of things that have to be done before these facet joint injections are covered. And when a RAC or a MAC or anybody else does one of these third-party reviews, they're just going to take that checklist and they're not going to say, well, Dr. Smith missed this one part, but everything else looks great, so we'll just go ahead and push that through. It's just going to be a recoupment. So
so skin substitutes are on the hit list because of the costs, the remuneration amounts, and the fact that nobody has documented these things correctly up till now. Terry, let me come to you, because it was really interesting during one of the sessions that the presenter said that, well, let me rephrase it. During one of the sessions, the presenter actually said the government is targeting telefraud as opposed to telehealth. And, so we get it with the marketing agreements. We get all these things that transpired. And I will tell you, they are going after COVID money like crazy. All of these 99211s, 99212s that were billed in addition to the collection, in addition to the specimen processing, they are coming after these things hot and heavy. But telehealth, again, is on the hit list for CMS, for OIG. Again, just quickly, talk about some of the biggest issues that you're seeing in the audits that you're performing for your clients with respect to telehealth services, because they're still having problems.
They're still having issues. I think the big thing that I see is nobody set up a timeline on when you could do what. And that's been the biggest and hardest thing with telehealth. And I don't know if you guys have run into this as well, but when just talking about Medicare, and then I'll talk about commercial for a second. But with Medicare, they seem like they change their mind every couple of weeks, every day. Well, first you can do this. No, you can't. Then you can do this. And now it went from 31 pages in that fee-for-service document, during COVID, the PHE, to, 312 pages by the end of it. And then they took down off their website, who's the qualified practitioners. I was getting calls from acupuncturists saying, can I do telehealth? And I'm like, tell me how that works. Recently, my daughter said that she was going to, somebody wanted to do a pap and pelvic. I think I remember that, through virtual. I'm like, you tell them that orange jumpsuits are not fun. I'm like, are you kidding me right now? it's expanded to the point where, and I get a lot of practices that they say, well, they're doing it down the street. I always get that. Well, they're doing it and getting paid. And just because you get paid doesn't make it legal or accurate or appropriate. And so I think we're in a unfortunate situation right now, not just with telehealth, but with everything, where providers are saying, tell me in writing where it says I can't do it. And there's certain things that you should just know you can't do it. You should just know that that's a problem. I it drives me crazy because we give them as much published guidance, as much, I mean, when I have to go from the CMS site to the payer language to the OIG to DOJ, and then I have to go to the False Claim Act, I'm banging my head against the wall. And, I had even one recently where they said, well, we ran it up to Flagpole, and the doctors that are legal and our compliance team, huge organization, big client, said, we're going to go ahead and let the doctor do that. After I wrote it up, and it was like, that you absolutely shouldn't do that. And so it's interesting because on the telehealth front, right now, we still have people saying, well, we're going to schedule an audio only visit to go over your test results. No, audio only is if the patient can connect. If can't connect during the time, you find out when they're scheduled for an audio and video that there's a problem during that video. It's not something you can pre-schedule based on how I'm interpreting the law. And so I don't know about you guys, but that's how I look at it. Is you're scheduled for an audio video, and if the patient can connect or refuses to for whatever reason, behavioral health sometimes, but they have better, a little bit more liberties, then an audio only, but you can't schedule it. And so,
Yeah.
I mean, Scott, we hear this all the time, but I just feel like, and there was a lawsuit, I think it was 2 years, we're 2025, it was in 2022, where there was a large group that, what do they call them, like Accountable Care Organization, that said, hey, they actually put it in a newsletter. Hey, you can bill twice a month telehealth visits just to make up for what you lost during COVID. And I was like, whoa, you put that out there? And now all those doctors are sending refunds now because as Sean said, we've got two, and I don't want to call them litigious, except yes, Secretary Kennedy, that's what you are. And I'm not saying it in a bad way. It's just that he's going to go after you if you do something that's shady or even suspect. But Scott, I know you want to comment on this. It's bad.
Yeah, I was going to say I got
I
a little
love telehealth,
excited
but
there.
not. Yeah.
I got a little excited there, or antsy, because I've started to tell my clients that here in May of 2025, with very limited exception, and when I say very limited, Terry referenced some behavioral health circumstances, you really should not be scheduling audio only anythings right now. If there are exceptions in various payer policies where the patient can drive it to audio for this reason or that reason, that's one thing. But we're kind of past COVID at this point. We probably shouldn't be scheduling audio onlys. And the other thing that I wanted to add, and I think this is related to, again, skin substitutes and a lot of things that we've talked about. If you go out and buy a used car, right, and you've got the salesman telling you all these things about this car, one of the things that most people will tell you, as my dad always told me, is just like, hey, spend a couple $100 or $100, bring in your own mechanic, have them look it over, get an opinion about whether or not it makes sense for you, rather than just believing whatever you're told. And I would say that about most services where you're having a conversation with a vendor, and they're practically, I used to love game shows, right? So they're practically counting out the money to you like they used to do on these old game shows, and you're getting blinded by the fact that you're gonna make all this extra money. It's gonna cost you very little of this windfall that you have coming in to go get another opinion about whether or not you should be doing that. I need somebody to bring me a coffee too, actually. No, it'd be very, it doesn't cost you much to get, doesn't cost you much to get another opinion about whether that makes sense to go forward, right? And I think that's oftentimes the missing link. Sean and I were recently involved in a 10x case where, this vendor was literally saying, well, the way you get around the payer's policy is you just write your usual tenotomy note and you don't reference 10x, because if you call the payer and you say, do you pay for 10x, they're of course going to say no. So instead, you just describe it as a tenotomy,
Yeah.
and you do the regular note, right? And Sean and I are both, our faces are contorting wildly.
I
on
mean,
this
the guy
video call.
literally said, just don't put the approach in your note.
Oh, he said this is how you get around it.
Oh yeah.
Oh.
And when we got on there, it was very clear. Not only did you have the legal department on there, you had Scott and I that were in the compliance department, and then you had all these others that were listening. So it was just mind-boggling to me. But real quick, there were two other things that are on the OIG's watch list. Terry, one of them you're going to want to plug your ears. But Paul, UDTs are all over the audit trails that the government's going after.
What is
the
that? I don't know the acronym.
Urine drug testing.
What is it?
Urine drug testing for chronic opioid
sorry.
therapy or substance use.
Sorry, the crashing waves distracted me. Sorry.
Nobody likes a bragger, Terry.
Sorry, the sounds of paradise. I couldn't hear you.
Okay. So one of the things that I think prosecutors continue to make a huge mistake on when they're trying to make a determination on bringing a charging document against a provider or an indictment is they continue to say that you cannot, in absolutes, you cannot order a screening and confirmatory at the same time, which we know is not true, because the LCD in the region where the prosecutor is saying this actually contradicts what he's saying. And hey, if we have to abide by an LCD as providers, the government has to abide by the LCD as prosecutors. So, UDTs are on there, but the other one that is on there, and this is the one that I think is going to cause more problems and wreak more havoc than anything else. And Elin Kuntz, who I absolutely love her. She's fantastic. She gave a presentation at HCCA. If you don't know Elin, she was the whistleblower for Halifax. And she did a presentation on split shared services, but addressed Incident 2. I will tell you, she did an absolutely fantastic job. It's not often I am able to have almost 100% agreement with people on Incident 2, but I was like 99% there with her. And it's not because she said anything wrong. It's some of it is philosophical because there's some ambiguity in the way that the Incident 2 guidelines are written. But
Sean,
here's the thing.
Before you go on, I just had the very first audit from UHC for practice on shared split visits. And I thought, wow, we've just changed the rules in 2023. That was quick.
Oh,
and here's what it was. And all the money's going back. So they tried to bill based on time, who had more time, but the only provider that put in time was the nurse practitioner.
Of course.
And they said, well, we have, the doctor obviously had more time. And I said, but the doctor didn't document how much time.
It's not obvious. It's not obvious.
Have to document time. And if it's substantive that you're looking at, both providers have to document what they did.
Yep.
And neither happened.
Yep. 100%. So here's what I'm going to say. Split shared services. I'm not so opposed to split shared services. Just understand that the person who documents the bulk of the time is who's entitled to the payment for the services. Okay. It's not who says, I was there for the creation of the plan of care. I was present for portions of the history and physical. No, that doesn't count. This is about time. Who spent greater than 50% of that time or the substantive portion of time. But shared services are a little easier to figure out, right? But Incident 2, Terry, plug your ears. They are on the OIG's work plan this year. They are actually doing a dedicated study to Incident 2 billing provisions, and they're going to issue a report in 2026. My 100% position is they are going to say greater than 90% of the groups that they audited got it all wrong. And I think they're going to make a recommendation to the Centers for Medicare and Medicaid Services to abolish Incident to services. My position, which has always been my position, get every one of your PAs and nurse practitioners and other qualified healthcare providers credentialed, and forget about this little 15% bonus, which equates to almost nothing these days. Bill it under the non-physician practitioner's number. Don't try to figure out, was this an established problem with an exacerbation or, a new problem, and how do we have to just stop? Incident to, they are amongst the most complex provisional billing services. They create the most problems for providers, and they create the most amount of arguments between consultants.
Well, didn't the GAO a few years ago say they wanted to abolish Incident to?
I've heard some folks talk about it. Scott Kraft and I actually spoke with Seema Verma. Scott, if you remember that, and we did an interview with her, and we said, hey, there's some rumors that Incident to services may be going away, and she's like, they're not going away. If anything, they're going to be revised again. I don't know, man. I'm really hoping that they just get rid of Incident to, keep split shared. I think they've done a very good job of explaining the who, the what, the when, the where, and the how, or the why. But Incident to is just an absolute nightmare. But Paul,
well, it is because
yeah, go ahead.
And Paul,
go ahead, please.
To you after this, I think the one thing that people don't understand, and I maybe this is just me, most patients that go to the doctor will cancel if they feel great. They're like, I'm fine.
Yeah.
I'll just reschedule. But they don't cancel when they want to tell them about something else that's bothering them. And that's not going to be Incident to if it's new.
And remember, there's no such thing as a healthy Medicare beneficiary.
Well, I think, I think there are just too many variables within Incident to operationally, where it is very hard to set a policy that you can maintain control over. So, I probably said this on the podcast before, but when I'm training people on Incident to, or I'm asked to talk about it, once I get past saying the same thing Sean said, which is like, please don't do it, it's not worth the money, but they're adamant they want to know about it, the PAs and the NPs are the people who need to have the most concrete understanding of what the policy is, because the patient is scheduled a certain way with an intent to be billed a certain way. And when that bus leaves the station, it's very hard to get it off the road when you need to, right? And the only person who can really do that is the NP or the PA. So if I'm a patient and I come in for my follow-up for hypertension and diabetes or whatever, and it's really, I need the refills, I'm stable, I'm well managed. And you think about that as like, okay, that's the characteristic of an Incident to visit. If I then say when I'm in the room, well, my shoulder's been bugging me, or, I find I've had like a lot more soreness lately when I get up in the morning, nobody knows that, right? Like I've gone on this tangent, and if the PA or the NP doesn't stop that, then that's going to go out as an Incident to service, and somebody looks at it, they're going to say, well, no, it can't be an Incident to service. They ordered an x-ray, or they gave out a muscle relaxer, or they did whatever they did.
Yeah. So Paul, very quickly, talk about the urine drug testing and issues that you have seen, and just very quickly, high level, what should providers be documenting to remain compliant?
Okay, I will move to that, but I do want to talk very quickly about virtual supervision.
Yeah, please.
I love the word virtual in our modern parlance, and I have taken into my soul the following phrase, and it applies to AI, it applies to cryptocurrency, and it applies to virtual supervision. Virtual anything is not anything. You're there or you're not. It's there or it's not. It's money or it's not. I could walk into a bar and say, "Hey, ladies, I'm George Clooney." You know what happens? The bartender's like, "You can leave now." That's virtual anything is not anything. So just stop that.
You do have good George Clooney hair.
Well, yeah.
All right. Let's go on. I digressed.
But UDTs, the biggest issue that we've dealt with, obviously, there are states that are dealing with the opioid epidemic in ways that are much more profound than other states. There are predatory providers, particularly when I say the term Florida Shuffle, that have basically exploited people with addictions or who are attempting to break opioids with ridiculous amounts of drug testing, where providers that we're dealing with, reputable pain management providers across the United States in all sorts of different jurisdictions, in all different MAC types, they have to deal with the bad players in the space. And one of the bigger issues that we're dealing with, yes, we have LCDs and they're finally coming around to being explained in more detail as best as they can, although a lot of the MAC LCDs kind of blend into one another after a while. But one of the big, Scott talked about variables. Let's talk about state law, where there are some states that mandate much more testing than what is put forward in a local coverage determination, and how those things move along and what they expect to find at certain intervals versus some of the standards are, it has to be random in order to do something. But, the Medicare Advantage, particularly Humana in the Medicare Advantage space, who says, well, you just don't have that many drug classes, so you just can't bill the highest level of, qualitative testing when we're following up to test drug analytes. There needs to be not just a federal consensus, but a consensus that trickles down to the states that says, this is what we expect to see, and there is a difference between opioid addiction, which we are expecting to drop off, and chronic opioid therapy, where these patients are in severe pain. They are being managed very carefully by a physician, and for purposes of continuing that expert level of care, there needs to be a laser focus on the types of medications that that person is ingesting on a regular basis in order to continue that therapy. And knowing that there are many drugs within an analyte family, are they only following their prescription regimen, or are we seeing an unexpected positive result, an unexpected intensity of result with the presumptive testing? A lot of this goes in. I think too many people are, and this really covers everything that we've talked about today, from skin substitutes to collagen substitutes to incident 2. It's all about utilization. Really, it's, the money is generated because of utilization. That's really where it comes from. And if you're getting a comparative billing report or CBR that says, hey, we notice you're doing a lot of skin substitutes suddenly, or you're doing a lot of collagen skin applications suddenly, that's a red flag. And if you are bringing in any service that is new to your practice, understand that it is immediately going to draw scrutiny because your utilization prior to that date is 0. So when it goes from 0 to many, somebody is going to pay attention to it.
Yeah, great points. And this is why it's so critical with everything that we've been talking about today, that if you have a compliance program and you haven't done anything with it recently, you got to dust off the bottle. I mean, you got to get the dust off of this thing. You've got to open it up, figure out what's applicable, what's not applicable, what needs to be updated, what should be removed, what needs to be added, because there's been so much that has gone on just over the last 24 months coming out of the public health emergency, seeing all of these new services that have come to light, all of these things that are being targeted. And it doesn't matter what your specialty is, there are targets on just about every service type and just about every recognizable CPT code. Creating that culture of compliance means the difference between being able to demonstrate a good faith effort versus a prosecutor saying, I think you guys are complicit. I think you actually knew what you were doing. You know, the scienter comes into play, you know, materiality comes into play. All of these different things come into play. So, you know, that culture of compliance, you got to figure it out. But the last thing that I want to talk about with the last few minutes that we have is, and I'm probably going to wind up doing just a solo podcast on AI in healthcare. Paul, you alluded to it. You made a comment about AI. We're seeing more and more reliance by providers on the use of artificial intelligence for creating their progress notes, not recognizing that there are multiple opportunities within a progress note for hallucinations to occur. And I'm not talking about bad LCD trips, right? I'm talking about hallucinations where information is pulled from different sources to be able to create a citation. But when you click on the citation, there is no actual citation for it. It's not real. It's a hallucination. There's other ways that the systems hallucinate information as well. These programs that are used to capture the dialogue between a provider and a patient during an encounter and then creating clinical summarizations for these, they're not working the way that some of these EMR companies proclaim that they're going to work. And I think AI, while there's a lot of good with artificial intelligence, I think there's that much more bad that's happening with coding, with documentation, and with creating clinical summarizations for the patients. And I'll open it up to all three of you for your final take on that. Paul, I'll start with you, then we'll go to Terry and then Scott.
You know, I like the fact that you made a reference to a dirty bottle earlier in the podcast as it applies to compliance. Yeah. One of my favorite episodes of television ever is the Twilight Zone episode, The Man in the Bottle.
Yeah.
It's not about the wishes. It's about the consequences of the wishes, you know? So, you know, it's lovely to have $1 million until somebody comes by and says, hey, you have $1 million. I think we'd like a piece of that back, you know? So it's, you know, be careful what you wish for. You know, it's not going, you know, and I use this in many aspects of everyday daily life. You know, the consequences of that wish are going to far outstrip and exceed the simplicity of the wish as it was generated in your head. And so it is with AI. You know, your life and your thoughts and your brain is your own. It's about time you started using it.
Yep. Terry.
Well, I think that the problem we have with a lot of things that technology does for us is people use it as a substitute instead of as a tool. And, you know, we're trying to give all these tools, like EMR was supposed to be a tool so that we could actually read their notes. I mean, I've been auditing and you know, coding and all this stuff since the 80s when we had to type our charts and type our claims and hold the doctor's notes up to the light to see what they're trying to tell us. And then I was excited about, you know, electronic health records, thinking, well, I'm, you know, going to be out of a job in that part. And it's actually gotten worse. And then when we could, because it's all so canned and relied on and, you know, again, substituted for actual physician concepts because they're smart phrases and drop downs and auto-populated fields. And then we get to AI and, you know, like Paul was saying, and it's just so, you know, doctors are AMA said you're only allowed to use it if you review the note. Well, I have physicians that aren't even reviewing annual well visits and, you know, that are being done by the RNs, and there's a complaint and they are not addressing it because they didn't review it. So then you go to AI and they're like, no, it's fine. And not just hallucinations, but AI was supposed to be nonprofit. Anybody who submitted for AI, it was supposed to be a nonprofit company. There's 2 lawsuits out. One is against ChatGPT because now they're for profit. Well, when you get for profit and you've got investors there's a slant on bias. There's a slant on what they want that to do, So, and then I'll obviously throw it to Scott. I'm nervous about AI, especially in healthcare. I don't think I don't think it's ready. How about if I say that?
Fair enough.
I agree, and hopefully this will make sense. And if we do a whole hour on AI, I'd love to be a part of it because I'm somewhat fascinated by it. But in addition to what everybody else has said about, the responsibility to review the note and take, not use it as a crutch or something like that, one of my concerns is, and I'll try to explain this. It may only make sense in my own head, but necessity is somewhat influenced by time, right? Like there's affinity to time that forces us to focus on what's necessary. So a common thing that a provider will say to me is, I only have 15 minutes in this appointment slot. I only have 20 minutes. So I need to focus on what's necessary. Likewise, when providers are constrained in how they document, they tend to focus on what's necessary. So one of my concerns with AI, and I know, some of the groups I've worked with are talking about using these sort of ambient AI systems, is like having to make a determination as a non-clinical auditor what is extemporaneous detail that's not related to the service versus a tendency to just bring in all of these data points and issues that may not contain a lot of pertinence relative to whatever the provider is treating. So when I say that about time and necessity, if a doctor could spend 90 minutes with every patient and it was agnostic to finance and everything else, I'm sure they could dive into and document a lot more things that were going on with that patient in a lot more detail. So that when it came to me as the reviewer, I would say, well, there's this condition and this condition and this condition. And so my concern with AI as it works in this function and as it's not necessarily a ready for prime time tool is we're just going to find a lot of extra detail in there that's going to tempt us to go to higher code levels. But it is sort of like fool's gold. It's fool's gold. I've said it twice today, where it's things that they're not managing, they didn't intend to manage, but we're all just sort of, we don't know what to do with it, and it's driving like higher utilization, and the regulators are coming in and pumping the brakes on that. So, I think to Phil and Terry's point, it's probably good. Will keep us all working for a number of years, but I have pretty significant concerns about how that comes together.
All right. Well, that takes us to an hour of the roundtable. I want to thank Paul, Terry, Scott for taking time out of their schedules and for jumping back on. We look forward to having Stephanie and Christine back on the very next episode, which will be in 2 weeks. Terry and I will have our hashtag Terry Tuesday episode tomorrow. And then later this week, I'm going to do a whole episode, and maybe Scott will join me on AI, and we'll talk about the good, the bad, and the legal ramifications for not understanding how to appropriately use artificial intelligence. So again, thanks to each and every one of you for tuning in, logging on, and hanging out with us. We are so grateful to be back. We've missed everybody. We hope you have enjoyed today's program. As I said, we'll be back in a couple of weeks with a brand new episode with the whole entire crew back, hopefully in their own places. Terry, she may or may not return from Hawaii. Who knows? So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care. All right.